Hello, my name is David McIntyre and I'm a Professor of Medicine and Endocrinology at the University of Queensland in Brisbane, Australia. And I've worked both clinically and in research for many years regarding treatment and diagnosis of diabetes in pregnancy. Today, I'm happy to share with you my thoughts on the diagnosis and treatment of gestational diabetes in the context of the current COVID-19 pandemic. Hello. Well, today I want to talk to you about the diagnosis and treatment of gestational diabetes during the COVID-19 pandemic. And here in the lower part of the slide, you have a picture of my hospital, the Mater Mothers Hospital in Brisbane, and I'm also affiliated with the University of Queensland. Now, both COVID-19 and gestational diabetes are alarmingly common across the world. On the left-hand side of this slide, we have a depiction of the relative prevalence of COVID-19 taken in the middle of August 2020. And you will see that there are a number of areas, particularly throughout the Americas and also through the USSR and many areas of Africa, which have a high prevalence of COVID. And you'll see on the right-hand side, if we look at GDM, that a number of these areas, particularly areas such as South America, also have a very high prevalence of gestational diabetes. And thus it is inevitable that these two conditions will essentially coexist and that we'll have to deal with the effects of both in a coordinated way. And really the presentation today is to discuss how these two conditions interact and how we might best deal with them. Another point I would make about COVID in general is that the information is changing rapidly. Now, I don't think there's any need to look at the detail of these, but you will see a number of major policy announcements and events documented here between a relatively brief period of December 2019 and around about May 2020, you'll see so many discoveries and so many events that have happened relating to COVID-19, so that things that we thought were absolutely up to date even a couple of days ago are frequently out of date by the time we develop and implement policies. So this means that we can try to adapt, or we can try to keep up with this rapid pace of change, but really almost everything we do has to be adaptable, and we have to be ready to modify our approach in the light of new information. So what then are the specific issues of GDM in the context of the COVID-19 pandemic? Well, I think firstly, there is the general question of COVID-19 and its effects on the delivery of care for pregnant women across the world. And then related to GDM in particular, there have been many concerns expressed regarding the oral glucose tolerance test itself and the fact that this may require a 2 to 3 hour attendance at a pathology collection centre in the midst of a pandemic, and that attendance is potentially avoidable exposure for the woman, where she is obliged to be in what may potentially be a high risk situation. So as a result, there have been a number of suggested changes to the way in which people might test for gestational diabetes. And there have also been alternative means of avoiding actual exposure to COVID-19 during the testing process. The next important issue relates to the healthcare resources involved, and particularly in lower resource settings. Both the testing for gestational diabetes and treatment for gestational diabetes involve use of a certain amount of healthcare resources, and these may either not be available or they may be stretched or need to be devoted to the treatment of COVID-19 patients themselves. And as a result, we have seen a large number of very rapid changes in the way care is delivered, in particularly very rapid uptake of telehealth solutions and the use of either video or telephone consultations. Something that has been less thought about but is nonetheless relevant is the organisation of postnatal follow-up and care, both for mother and baby. And in all of these issues, there is the question of the relative value of diagnosing and treating what is an infectious disease crisis in the form of COVID versus the global burden of non-communicable diseases, which contribute enormously to overall healthcare burden and overall healthcare expenditure across the world. And we also have that context where we have currently a short-term or acute problem, and then we have a long-term risk relating to the health both of mother and baby. So one of the first bodies to issue some general guidelines regarding pregnancy and COVID-19 was FIGO, or the International Federation of Gynecology and Obstetrics. And you'll see, and no doubt know, a number of the people involved here, including particularly from Hong Kong, Leona Poon, and Professor Yang, also from China. I was also an author on this paper, as were a number of colleagues from around the world. Now, this was a very early publication in March, April 2020, put together quite rapidly in response to what was an urgent clinical need, and also involved a number of centres, for instance, those in Italy and those in China, which had had early experience in the treatment of pregnant women with COVID. And the focus at that stage was on immediate management of the patient with suspected or diagnosed COVID-19. And in fact, other maternal risk factors such as gestational diabetes were of relatively minor importance at that point. And FIGO did not suggest in this document any systematic change to the way gestational diabetes would be diagnosed. Now, just to recap a little, you may recall that FIGO has issued some guidelines in 2015 regarding the way one should approach testing for gestational diabetes, both in early pregnancy and standard pregnancy. And in this document, there was a worldwide and preferred option, which involved testing in early pregnancy designed principally to detect undiagnosed type 2 diabetes. And this recommendation was for either fasting glucose, hemoglobin A1C, or a glucose tolerance test, depending on the local resources and also the local likely prevalence of diabetes mellitus. And then the standard testing at 24 to 28 weeks was recommended as a universal 75-gram 2-hour glucose tolerance test with the thresholds for diagnosis as recommended by IADPSG. Now, despite this global recommendation, it was recognized that a number of countries or areas around the world had developed their own processes based on local data. So some of these other options were certainly accommodated in the FIGO guidelines. For instance, in China, the practice was for a fasting plasma glucose at first visit, and this was well supported by local data. And gestational diabetes was considered present if the fasting glucose is in the range 5.6 to 6.9 millimoles per litre, or diabetes in pregnancy or overt diabetes if the fasting glucose was greater than 7 millimoles per litre. Now, the standard approach in China gave really two options. If the early test was negative, the fasting plasma glucose could again be performed with GDM diagnosed at a threshold of 5.1, or GDM ruled out effectively if there was a value of less than 4.5 millimoles per litre. Now, this Chinese protocol allowed for glucose tolerance tests to be performed only in women with fasting glucose values between 4.5 and 5.0 millimoles per litre, or alternatively in some centres where there was full resource availability for a full 75-gram glucose tolerance test, as in the general guidelines, to be the first test. And this becomes important when we consider some of the altered recommendations, particularly from Australia, in the context of COVID. Now, as you'll see, the recommendations in India were quite different again, and they generally involved a non-fasting test. And much of this was due to the logistics of difficulty of women attending fasting with prolonged travel to their hospital centre or clinic to have a full fasting glucose tolerance test. And India has tended to use these DIPSI criteria diagnosing GDM on a 2-hour result after the glucose tolerance or the glucose load test of 7.8 to 11.0 millimoles per litre. And in some centres has used other tests such as HbA1c. And you'll see that the UK again had quite a different approach. They have never favoured, in the recent guidelines, universal testing. They still favoured testing based on the presence of risk factors, such as family history of diabetes, obesity, or previous gestational diabetes. And they used quite a different set of cutoffs, with a much higher fasting cutoff of 5.6 millimoles per litre, but a relatively low 2-hour cutoff of 7.8 millimoles per litre for diagnosis of gestational diabetes. And again, at 24 to 28 weeks, or for standard gestational diabetes diagnosis, the UK used those same risk factors in the presence of a negative early test and the same diagnostic criteria. So you'll see that even before the COVID pandemic, there were quite marked differences around the world in terms of GDM diagnosis. Now, there are a number of countries that moved or published guidelines fairly early on in COVID-19, and this is a summary of the ones we knew about first, I guess, out of all of those. So the United Kingdom, the College of Obstetricians and Gynecologists came up with recommendations for risk factor-based testing as before, but without any glucose tolerance tests. They instead wanted to depend on hemoglobin A1c and either a random or preferred a fasting glucose. And these were the threshold values they promoted. Hemoglobin A1c of greater than or equal to 5.7%, as often used to define impaired glucose tolerance or impaired fasting glucose outside pregnancy. They accepted a fasting value of 5.6 millimoles per litre as diagnostic, or a random value greater than or equal to 9 millimoles per litre as diagnostic of gestational diabetes. The process in Canada was quite different again. Their pre-testing process involved universal testing, but with a 2-step process, with the non-fasting 50-gram glucose challenge, followed, if that was positive, by a 75-gram glucose tolerance test. In their revision, this was actually fairly radical. They wanted to proceed to universal 1-step testing, but totally abandoning the glucose tolerance test and testing with a combination of hemoglobin A1c and random glucose. And again, they used a hemoglobin A1c threshold of 5.7% for gestational diabetes, but really a very high random glucose threshold of 11.1 millimoles per litre, which outside pregnancy would usually raise suspicion of undiagnosed type 2 diabetes. Now, Australia was the only one of these 3 countries that pre-COVID suggesting universal testing with a 75-gram glucose tolerance test. And post-COVID, their recommendations were somewhat different. They've suggested still universal testing, but with a process in some ways very similar to what has been done in China, using a fasting glucose of greater than or equal to 5.1 millimoles per litre as consistent with gestational diabetes. For fasting values of 4.7 to 5.0 millimoles per litre, it was recommended the patient should continue to a full glucose tolerance test. And in the Australian context, the fasting glucose of less than 4.7 millimoles per litre was to be accepted as normal. And you will see that except for the choice of the fasting cutoff, this process for the use during COVID in Australia was actually quite similar in many ways to what has been recommended in China as a general recommendation. So then I would like to draw your attention to our recent published study in diabetes research and clinical practice, where we aim to assess both the GDM frequency and the outcomes using these 3 proposed protocols for the United Kingdom, Canada, and Australia. And we were fortunate to have access to around about a quarter of the HARPO cohort. We had almost 6,000 women from USA, Hong Kong, and Australia. And these women had undergone both a full diagnostic glucose tolerance test and hemoglobin A1c during their pregnancy. And the results of the glucose tolerance and all other glucose values were blinded, and they were not treated. So using this cohort, we were able to compare the UK, Canadian and Australian approaches as modified during COVID, both in terms of the number of women who would achieve a diagnosis of gestational diabetes, and also in terms of what that meant in terms of the number of outcomes of interest which would be detected or missed by the modified COVID testing protocols. So these are the numbers with the pre and post-COVID modifications. And I must just stress that in the UK, of course, they were only doing selective testing, so they may have in fact missed some cases early on. And in Canada, they were using a glucose challenge as their screening test rather than a universal glucose tolerance test. And also they were favouring random glucose rather than fasting glucose. In any case, using the numbers as provided, we come up with quite a marked decrease in the UK from 12.9% GDM pre-COVID testing right down to 2.5% with their post-COVID protocol. In Canada, they use somewhat higher threshold values for diagnosis of GDM, and their rates would fall from pre-COVID diagnosis of 9.3% to post-COVID diagnosis of 1.7%. And in both these countries, that would represent about an 80% decrease in the number of GDM diagnoses. Now, with the Australian changes being less marked, the GDM frequency would only decrease from about 17% to 12.7% from the pre-COVID to post-COVID stage. And you'll see that in this cohort, however, even at baseline, the number of women in Australia who would be diagnosed with GDM was around about 1,000, whereas in Canada, it was only a little over 600. So you'll see even at baseline, the differences are markedly different, but the effect of the COVID changes are much, much more marked in the United Kingdom and Canada. Now, we know then that those numbers are lower in terms of absolute women with GDM, but the secondary question was, what are the consequences of these change in terms of clinical outcomes? So we'll deal with these country by country, and this is the UK analysis of pre and post COVID-19 diagnosis. And we essentially have three colours which follow through onto the other slides. We have those who were missed GDM. In other words, they had GDM by the pre-COVID criteria, but they would have been missed post-COVID. We had the group of women who were pre-COVID GDM and would still be detected by the modified post-COVID process. And then we had those women who were non-GDM. And you'll see in terms of the UK, the women who were still detected as GDM post-COVID had somewhat higher rates for all of these outcomes. So this is pregnancy, hypertension, preterm birth, large for gestational age, excess neonatal adiposity, and caesarean section. And for most of these, the missed GDMs were at a little bit lower risk, but still substantially higher risk than the non-GDM women. And this is true certainly for hypertension, preterm birth, large for gestational age, neonatal adiposity, not really so for caesarean section rates. So the post-COVID GDM women certainly had a somewhat more severe form of gestational diabetes with higher risk of complications, but those who were missed also for many outcomes had substantially higher rates than the background non-GDM population. If we look at this in a slightly different way, and then look in this red column about what the percentage of outcomes actually was and how many outcomes were actually missed, you'll see that by making these changes in the UK, they reduced their numbers of GDM by about 80%. They missed around 50% of hypertension, but they also missed almost 80% of preterm births, LGA, neonatal adiposity, and caesarean section. So if you were trying to modify those outcomes by making this change in diagnostic process, you would have missed a fairly large number of outcomes, particularly for everything except hypertension over here. So that is quite a change when you consider the data in that way in terms of how many women would have been subject to GDM treatment and perhaps had these outcomes prevented pre-COVID, and then there would have been no outcome opportunity to prevent outcomes in the post-COVID setting. Now, this is the Canadian analysis, And as I mentioned before, they also reduced their GDM detection rate by about 80%. But you'll see in this case, the women they excluded, or the women they missed after the change in diagnosis, carried almost exactly the same risk for most of these outcomes as did the ones that they still detected after COVID. And in each case, these outcome rates were much higher than the women without GDM. So in other words, they ended up excluding from treatment women whose actual risk of various complications was almost the same as those that they continued to treat in the post-COVID context. And this, again, following the way I've presented it in the previous slides for the UK, just shows that they reduced their GDM diagnosis rate by about 80%, but they also missed 80% or more of the outcomes of interest as presented there: hypertension, preterm, large for gestational age, excess neonatal fat, or cesarean section. So one could question the efficiency of this approach, because by reducing their GDM, they also missed most of the opportunity to intervene and prevent adverse outcomes. If we move then to the Australian analysis, this is actually somewhat different. You'll see that, as we mentioned before, a lesser percentage of women were missed under the Australian approach, and these are their outcomes. That for the missed GDMs, yes, these women had lower outcome rates, in some cases actually lower than the non-GDMs, but in most cases at least not substantially higher than the non-GDM group. And the women who were still diagnosed post-COVID were showing much higher outcome rates across all of these outcomes. So although for some outcomes, such as LGA, the women who were missed still had higher event rates, they were still not enormously high. So this rate of LGA, for instance, is around about 12%, only a little more than the 10% predicted. And for neonatal adiposity, also the rate was a little bit less than 10%, which would have been the predicted outcome frequency. So in other words, the women who were missed using the Australian approach, which, as I mentioned before, is somewhat similar to the current Chinese approach, were less severely affected by their GDM. And then we look at this in terms of the same analysis of percentage of missed outcomes. You will see this reduced the number of women with GDM by around about 25%, but the number of outcomes missed was more in the range of 10 to 15, possibly 20%. So that percentage of outcomes missed was less marked in the Australian context than in the other UK or Canadian analyses. If we just look at this between the three sets of potential criteria or modified criteria for COVID, you'll see that in general, the number of outcomes missed as a percentage of baseline is greatest in Canada, then the UK, and then Australia. So this represents the actual cost of changing a diagnostic protocol. Now, the benefit of changing might be the fact that less women are exposed to a risk of COVID, might be that the clinics are less busy, but there is a cost in terms of women who could have been treated and were no longer treated, and the complications that they suffered. Since the time that we published this paper, a number of other countries or organisations have published recommendations, and you'll see many of them include HbA1c, most commonly with a cutoff of 5.7%. You'll see that Spain suggested one could use either random glucose or fasting glucose with these cutoffs for diagnosis. Italy came up with a fasting glucose only protocol that suggested risk factor based testing and used the IADPSG cutoff threshold of 5.1 millimoles per litre. And in France, they used a somewhat mixed protocol where you could have either elevated HbA1c or a fasting glucose greater than or equal to 5.1. So all of these could potentially be evaluated in our model, but for the purposes of our recent publication, we've only considered the three countries of the UK, Canada, and Australia. So interestingly, the question of early pregnancy testing after COVID-19 has a lot less evidence around it, but perhaps because there's less evidence, people have been more willing to agree on a consensus position. So almost all organisations have recommended risk factor-based testing. They have accepted a hemoglobin A1c in early pregnancy greater than or equal to 6.5% as consistent with diabetes in pregnancy or likely type 2. and they've generally taken hemoglobin A1C 5.9 to 6.4% as acceptable for diagnosis of GDM in early pregnancy. And some have also included the options of fasting or random glucose or even a glucose tolerance test, depending on the local prevalence of COVID, etc. So David Simmons from Australia has recently published an analysis of what these tests themselves mean. And you'll see for the glucose tolerance test, it does involve a lab testing time of over 2 hours, but on the other hand, it's definitive. It's one step and it doesn't miss any diagnoses. If you use a glucose tolerance test with only a 0 and a 1 hour and omit the 2 hour value, you will miss about 12% of GDM, but you will save some testing time in the lab. If you use only a fasting glucose, the testing time or the time in the lab will be less than 15 minutes, but there may be a concentration of women in the lab early in the morning. Now, this is predicted to miss around 20 to 25% of GDM, and that would be consistent with our data in Australia, but there are some ethnic variations. For instance, Chinese women tend to have a somewhat lower fasting glucose, so the thresholds would need to be adapted. In some other places, such as the Middle East, where women of Arabic descent have quite high fasting glucose, this might actually be a more effective strategy. Now, hemoglobin A1C, everyone would like this to work, and certainly it's a non-fasting test, a random test, less than 15 minutes, but the trouble is really in terms of its sensitivity. So even in good situations, hemoglobin A1C will miss around 75% of GDM diagnoses at a hemoglobin A1C threshold, generally set at 5.7%. This will vary in terms of red cell lifespan, reduced in pregnancy, ethnicity, and iron status. And I'll point out to you that in the HARPO study, the hemoglobin A1C threshold of 5.7% was around about the 99th centile of the HARPO population at 24 to 28 weeks gestation. So it really is not a very good test for detecting GDM, though those women who have an abnormal value clearly seem to have abnormal glucose metabolism. David Simmons and co-authors also considered random glucose, which obviously has a brief testing time, but this is obviously totally non-standardized in relation to its timing with diet and exercise, and will also miss at least 30% of diagnoses with a threshold of 7.5 millimoles per litre, and the results will be even worse if a less precise testing modality, such as a home glucose meter, is used. Now, some people have suggested that one does not even need to test if the women had previous gestational diabetes in a previous pregnancy, that we would accept that previous diagnosis of GDM as a current diagnosis of GDM. And this may sound easy, but we know that GDM recurrence in a subsequent pregnancy is lower than one might think, only in the range of 30 to 70%, and this varies greatly by ethnicity. So this is really a very rough means of diagnosing GDM. And some people have suggested we need no laboratory testing at all, but we could simply start women doing their home glucose testing as per GDM protocols at home. And that might be easy, but it has the disadvantage that these women don't actually have a diagnosis of GDM, and nonetheless we're treating them as if they had GDM, and there is actually no evidence to back up this approach, though it does sound superficially attractive. So what then of treatment for GDM during pregnancy? So there have been, as I mentioned, immense changes that have happened very rapidly. There have been very widespread adoption of digital health methods, internet-based care, telehealth, telephone consultations. And really, we are trying to balance this risk of the woman contracting GDM either in her diagnosis or during her clinic visits versus the risk of not really getting ideal care, including the fact that she may have GDM and that may not be diagnosed, but perhaps her visits will not be as detailed as they might have been before. And it has been pointed out very reasonably that in the actual pathology testing and the hospital visits, there's a number of preventative measures such as social distancing, hand washing, use of personal protective equipment such as face masks. These still remain important across all healthcare contexts, and they can in fact mitigate risks while still allowing appropriate clinical care. Very little has been said to date regarding care for GDM women after pregnancy, but clearly if you look at the health economic and the clinical studies, postpartum follow-up and the prevention of long-term progression towards diabetes contribute enormously to the clinical and health economic value of diagnosing and treating gestational diabetes. And essentially, a failure to diagnose means a failure to have this opportunity postpartum for longer term intervention for maternal health. So the few recommendations that are out there mostly favour delaying formal postpartum testing until after the pandemic. And we don't, of course, know exactly where that would be. And most of them allow that the occasional high-risk women who have much more severe hyperglycemia in pregnancy, some of which may actually be undiagnosed type 1, which is quite rare, or type 2, which is much commoner. These women who look like they'll have an ongoing problem should be followed up early and not allowed to just drift along in the absence of postpartum testing. The mode of follow-up postpartum remains to be defined. If we're still trying to avoid glucose tolerance tests, then perhaps the combination of HbA1c and fasting glucose outside pregnancy may be best. And very little has been said about the potential gaps in terms of the future health risks of the offspring of these gestational diabetic pregnancies. Now, I'll point out that there is a real tension between the COVID pandemic and the treatment of non-communicable diseases. And this has recently been highlighted by this World Health Organization report. And just to point out the top causes of deaths, you'll see that the red ones, this is pre-COVID, of course, in 2016, the red ones are infections such as respiratory infections, tuberculosis, and diarrheal diseases. But by far the biggest burden of disease and the causes of death across the world are in fact in the area of non-communicable diseases such as ischemic heart disease, stroke, pulmonary disease, and diabetes has now featured on this list, whereas 4 years before it didn't. So certainly diabetes is one of the increasing burdens of disease worldwide and still a major cause of death and contributes a lot, of course, to ischemic heart disease and stroke as well. So somewhat worryingly, the World Health Organization showed that services for non-communicable diseases were really very severely disrupted during the COVID pandemic. And if we look at diabetes, when the COVID spread had moved from just sporadic cases to case clusters to widespread community spread across many countries in the world, that 65% or more had quite severe disruption in diabetes services at the time that they were probably just as needed, because many of these resources were being diverted into other areas, particularly into the COVID-19 response. So in summary then, we have a large number of challenges reconciling COVID and the NCDs. First of all, the needs of COVID patients are clearly urgent and must be met immediately. And as a result, staff are frequently redeployed from one area or another to help meet these needs. Routine outpatient clinics may be closed. There's often disruption to transport, for public transport in particular. In the beginning of COVID, there was certainly a lack of personal protective equipment, though this has now been addressed. And importantly, many disease screening programs, including GDM screening, as we discussed, have been severely disrupted. And the training of young healthcare professionals may also have been ceased over this important time. And then there can be shortages of stock, both diagnostic and therapeutic, for the management of many chronic conditions. Now, just to point out that both gestational diabetes and hyperglycemia in young women are not uncommon problem. This has a summary of the rates of GDM we see in the HARPO study in the US, in Australia, and in China. And you'll see it's a substantial health burden in all of those. But perhaps more worryingly is that outside pregnancy, in the US, for instance, we see over 30% of young women between age 18 to 44 with either type 2 diabetes, diagnosed or undiagnosed, or pre-diabetes. And we also see high rates both in Australia and in China. And these are all severe health burdens, first often reflected as gestational diabetes. So I think we need to consider women's health across the whole life course. And we have only this opportunity during pregnancy to detect GDM as a risk factor for future maternal health. And also the health of the child matters too. And the diagnosis of GDM clearly carries serious implications both for mother and baby. So in summary then, and to give you some future perspectives, I've described to you multiple approaches to GDM detection during the COVID pandemic. I've noted that the evidence base for all of these is rather limited. Many of them have been empirical. Some very well-intentioned decisions were made quite quickly, and these were made rapidly and then put into action without full evaluation. I think now we need to take a step back and evaluate these decisions, both the diagnostic and the treatment strategies, and document what their effects have been over time. And we need to balance current health risks with future health risks and the acute demands of COVID with the long-term demands of non-communicable disease prevention and treatment. And we also need to consider whether some of these changes may actually be beneficial for incorporation after the COVID pandemic. So in summary then, I think as always, we're aiming to strike the right balance between this nasty virus down the bottom here and our ideal of having healthy mothers and babies into the future. And with that, I thank you very much for your attendance.